This is Dr. Scott Geller. I am an ophthalmologist in private practice in Fort Myers, Florida. My presentation here is a complete didactic course on laser vitreolysis, or as more commonly known, eye floater laser. This course will be very complete with a lot of background information that you may use as you wish. If you have a presentation you need to give to other ophthalmologists or perhaps referring optometrists, the course itself will have QR codes in the slides. The QR codes will go to bibliographies and references for various things in the medical literature, and you will easily access the information that you need to be knowledgeable in this. So let's start now. There's our usual disclaimer. I don't have any financial relationships with any manufacturer regarding laser and the vitreous. Those of you who take this course will be cognizant of the initial research and the interaction of biological tissue with YAG laser irradiation. We'll go over some early peer-reviewed papers on laser vitreolysis, and then we'll go over laser physics. When I first got into this, the president of the Lazog laser company from Switzerland was showing me his super laser, and he said, Dr. Geller, actually what I said to him was, why should I pay all this money for this laser when I can get something for half the price? And he looked me in the eye and said, Dr. Geller, what exactly do you know about laser physics? Well, of course, like most physicians, I knew a little bit. I had already taken a course, I believe it was by Dr. Kraft, perhaps many, many years ago on the first uses of YAG lasers for capsulotomies. But like most ophthalmologists, my knowledge was limited to pushing the button and knowing the clinical aspects of it. I really didn't understand or have a deep knowledge of laser physics. But once we go into that, we'll go into the potential complications of YAG laser in the vitreous. And certainly the most important thing is proper patient evaluation and selection. Then, last but not least, we will go over laser surgery techniques. Well, here's something that's very important for all ophthalmologists, something all surgeons know. Knowing what to do is not the problem. Knowing what not to do is. So I'm speaking with over 30 years of experience doing this. I studied under Professor Franz Funkhauser at the University Eye Clinic in Bern, Switzerland in the 1980s. I spent an extended amount of time there and saw things that no one else worldwide was doing. And at this point in my career, I probably have even way more than 20,000. It's probably more like 25,000 vitreous laser sessions. Let's go over a little bit of what I have presented worldwide. I've really been into this. This is a little niche specialty, or should I say subspecialty, for me. I enjoy doing it. It gives me great satisfaction to help people who are told nothing can be done. My very first presentation was in 1989 at the International Congress of Ophthalmology in Singapore. There were various other presentations throughout the 90s, and in 1997 I presented at the European Congress of Cataract and Refractive Surgery in Prague. 2001 at the European Congress of Ophthalmology in Istanbul, and at the Florida Society of Ophthalmology in 2002. The funny thing was, Dr. Dale Davis, I don't know if he's still in practice over in Miami, said to me, well, my patients don't have these problems. I think it just went over his head. I previously presented at the American Society of Cataract and Refractive Surgery in Boston in 2010. The subject of the course was unnecessary capsulotomies due to a misdiagnosis of vitreous floaters. I have presented at other international congresses, and you can see on the list it's been quite consistent and quite complete. My favorite presentations were in Italy at the Orioni Congress. It started 10 years ago, 2014, and I've gone back 4 subsequent times. I also did some eye floater laser at Dr. Orioni's practice on patients there. We don't have to go over everything else here. You can go over it at your leisure. We presented it at Rush Medical School, my alma mater, and at the Florida Society of Ophthalmology in 2018. That course is available online at myvimeo.com/eyefloaters page, as well as Scott Geller, MD, on YouTube. We gave a small course at the American Osteopathic College of Ophthalmology, and in 2023, I went to Europe again and discussed complications of this in Prague. In 2024, in case you missed it, a small presentation at the ASCRS meeting in Boston. And the subject was eye floaters as a cause of unhappy patients after refractive lens exchange. A very important thing for you to know. Let's get down to the meat of this. Does it work? Yes. Does it always work? No. So our goal is to get the best possible outcome given the limits of our current technology. Let's go back to the historical overview of YAG lasers. Many of our younger colleagues really don't understand what came before them. In 1985, Professor Funkhauser wrote of YAG laser use in ophthalmology and said it should receive increasing attention. Well, of course, there's a QR code you can scan, and that goes right to that article in the Journal of the American Medical Association. In 1983, there was a piece on retinal damage from Q-switched YAG lasers by Dr. Jan Pohl and Dr. Goldberg. I believe Dr. Goldberg was at the University of Illinois Eye Clinic in Chicago at that time. You can scan the QR code and see the actual paper. There was an article on IOL damage, intraocular lens damage, I should say, from YAG pulses focused on the vitreous. This was in the Journal of Cataract and Refractive Surgery, 1988. You can scan the QR code to see that. If you want to delve further into this subject, this QR code has a complete bibliography with several dozen papers on YAG laser interaction with a human tissue. Professor Funkhauser did some extensive research starting in the 1970s, long before YAG lasers were commercially available. Interesting work. You can access it through the QR code. So let's sum up these early papers. Most important thing, YAG lasers can be safely used 3 to 4 millimeters from the retina. And I think a lot of these early reports of failure and complications more or less poisoned the well. So who is this Dr. Scott Geller saying that he can work 3 millimeters from the retina safely when there's actually stuff in peer-reviewed journals that says that is dangerous? Well, of course it's dangerous if you don't know what you're doing, but if you are skilled at it, you certainly can come to the same level as me. You do have to have the right equipment. So let's go back here. Our current clinical papers. These are within the past few years. 2015, American Journal of Ophthalmology, paper on refractory glaucoma after YAG laser vitreolysis. 2017, YAG vitreolysis versus a sham YAG for floaters by Dr. Shah out of Boston. And in 2017, the same issue, there was a report of complications following YAG laser vitreolysis by Dr. Hahn and the American Society of Retina Specialists, a full committee with a hit piece, that's the best thing I can call it, on YAG laser vitreolysis. One thing you need to read if you're going to deal with floater patients who have these issues with dense vitreous opacities or even minor vitreous opacities is visual snow. Visual snow, in my experience, was diagnosed as eye floaters by very skilled retina specialists and university doctors. However, visual snow is a completely distinct neurological phenomenon. Most doctors don't spend that much time with a patient that comes in and says, I'm seeing these eye floaters, and they're younger patients, and it's like immediately they're put in the nutcase category, which is unfortunate. Let's go over some of these papers with a critical eye to see what flaws they have in their methodology and their conclusions. Dr. Shah out of Boston, well-known retinal specialist, said in this paper, laser ceased, that is the laser treatment, ceased after vaporization of the Weiss ring and all other visually significant floaters. Well, the title of the paper was Laser for Weiss Rings, basically, and he persisted in presenting this absolute myth that floaters are vaporized. I can tell you, as a matter of fact, they are not vaporized. Oh, there's gas bubbles, which are water vapor, of course, but they are not vaporized any more than a capsulotomy vaporizes a capsular tissue. An interesting finding in this paper is that 31% of the sham group reported improvement. Talk about placebo effect. Why would they report improvement? Well, I have several opinions on that. I think they might have wanted to please the doctor, and they were offered this treatment free of charge, and they knew the doctor was looking to prove that it actually worked. So they might have said, well, yeah, it works, just to make the doctor happy. The question is whether they would have reported improvement if they paid, let's say, $2,500 for several sessions. Possibly. I would say they probably wouldn't have. 8 of the 36 treatment patients reported no improvement. Yet Dr. Shah objectively reported 100% of the, I assume, Weiss-type opacities were gone. And he justified this with direct visual inspection, fundus photos, B-scan ultrasounds, etc. I attribute this to poor history taking, and I'll go into that later. And Dr. Shah also said there's no learning curve with this. Well, that's interesting. How did he have 8 out of 36 with no improvement if there's no learning curve? Think about that. Dr. Lim did a commentary in that same issue. She also repeated the misinformation of vaporization of eye floaters. This is not true. She also stated that this was a treatment of Weiss rings when it states in the paper Weiss rings and other vitreous opacities. I assume when she says Weiss rings, she means hyaline opacities, because very often these opacities are not ring-shaped at all. They can vary in size, but usually are in the same location in the vitreous. She also states that complications are unknown. Well, that's not exactly true. We presented a poster presentation at the 2012 American Academy of Ophthalmology going over all the potential complications that we have seen. That was with Dr. John Cataract, who was practicing at that time in Virginia. He has subsequently retired. Dr. Cataract invented the flange on a Goldman lens that prevents the lid from closing. A very little simple innovation. He told me he was trained as an engineer before he got into medicine. You can access that commentary with the QR code. Dr. Hahn, in his commentary, reported complications following laser vitreolysis. I considered that commentary to be a complete hit piece to dissuade anyone from getting into it, sort of with the attitude, well, you know, we tried this and it doesn't work and we had complications, so therefore anybody who says it does work probably doesn't know what he's talking about, because we are academic doctors and they are not. The Cowan piece on glaucoma after YAG laser, their conclusion was that it was a late complication, late onset. But if you read the body of the paper, you'll find that after laser vitreolysis, there was quite a prolonged period of time before the patient was ever seen by an ophthalmologist. So they can't really say it's a late complication. They can only say that the complication was observed months after the procedure, and there was no observation immediately after the procedure. And I can tell you from my own experience that elevated intraocular pressure does occur in certain cases, usually 24 to 48 hours after the procedure. So let's get down to some other aspect of this. Let's review laser physics, something that you may or may not have learned in college, other than this is a pointing laser and I use it when I give a lecture, or this is a YAG laser and this is what I use in clinical work in my office. But let's review the actual physics. So when you go out and give a lecture to colleagues, you at least know what you're talking about. So what's the common structure of all lasers? It's very simple. There's a pump source, which is driven by electrical energy going into light energy that is focused on the material used to create the laser phenomenon. In a YAG laser that we use, at least the one I use, it's a man-made crystal. There are mirrors at both ends of this man-made material, and these mirrors are 100% at one end and less than 100% at the other end. And when the light travels, and I'll go into that in a minute, it comes out of the outcoupling mirror and you get the phenomenon of a laser light beam. So let's go over the neodymium YAG laser. Neodymium is a rare earth element, and neodymium atoms are, as they say, doped into the YAG crystal. Doped means that it is dispersed uniformly. YAG is an acronym for yttrium, aluminum, garnet. The formula is Y3, Al8, and O12. It's a cubic crystal in its structure, isotropic, and it is transparent. 1% of the yttrium is substituted with neodymium. And if you really want to get into the details, that is 1.38 times 10 to the 20th power atoms per cubic centimeter. The pump sources that excite this crystal are usually xenon lamps. Xenon lamps are the same things that you have in a flash camera, if you remember what a flash camera was. In the case of the laser I use, the crystal's housed in an ellipse-shaped reflector. It's gold-plated so it doesn't corrode. The flash lamp focuses all the photons on the YAG crystal, and we have the two mirrors at both ends. This is an actual photograph of the YAG laser, or I should say the laser box, or laser cavity, as they would say in physics. This is the laser cavity, gold-plated, so there's no corrosion. The YAG crystal is that thing being pointed to by one of our laser experts from Switzerland who comes over to service my unit. The housing is water-cooled, which gives it much greater capability versus a diode-pumped laser, which are very common in ophthalmology. Most of the lasers are, as we call them, diode-pumped. This is the inside of the external part of the cavity that on the left-hand side of the screen is a 100% mirror. On the right-hand side of the screen is a physical device called a Pockle cell. A Pockle cell is a liquid crystal that opens and closes and allows the laser phenomenon to happen. So let's go into the spectral range of medical lasers. At the lower end, the ultraviolet end, we have the argon and krypton lasers. Most ophthalmologists are familiar with argon lasers. They're used in retina work. It's in the UV ultraviolet spectrum. In the visible spectrum, we all know what those are because we've seen them. We use them. They're the little pointing lasers that we use, the Heine lasers, Heine meaning helium and neon. Also, the krypton and argon lasers can also have some fluorescence in the visible spectrum, and so can ruby lasers. The ruby laser was the very first laser ever created. Ruby lasers were made by the Zeiss company, and when I was a resident, Dr. Beckman was the chief, and he was very much into lasers. The ruby lasers were quite destructive. That's very old literature. There's probably very few of us who've actually seen them. Well, as we go into the spectrum a little more, with the longer wavelengths, we've got the near infrared, where we see the neodymium YAG laser. And when we go into the medium infrared, we've got the CO2 laser, which we've used for cutting in blepharoplasties and other applications in surgery. So what's the characteristic of a light wave? Well, this gets into the esoteric parts of physics. If you look at this drawing, we've got E being the amplitude of the electrical field. The x-axis is the polarization direction, and the centimeters means the propagation velocity. In radiometric terms, we've got power, parentheses watts, is joules over time. Irradiance is the power in watts per centimeter squared, as seen in this formula here, P over A. Energy in joules is equal to power, as we can say in watts, times time. What's the radiant exposure? That's the joules per centimeter squared, which is energy in joules over the area in square centimeters. So you can impress your colleagues with all your knowledge of this esoteric stuff. So what are the properties of laser beams? Well, there can be several different ways a laser works. In the graph on A, we see increasing pulse energy at a constant beam power. On the lower left, we've got increasing beam power at a constant pulse energy. The laser pulses actually have a graphical shape. You can have a more or less square pulse, or you can have a pulse that has a more Gaussian distribution, as seen in the middle right diagram and the lower right diagram. So let's go over the laser process again. In the laser material, or I should say the laser rod, all the neodymium atoms are in a ground state. When the neodymium ions are irradiated, the energy is stored, and this stored energy is released by the spontaneous emission in all directions. In other words, think of a fluorescent lamp. You've got two electrodes shooting electrons out through this hollow tube. The energy is actually scattered, and it hits the powder on the inside glass of the tube, and it fluoresces. Now, what is really necessary for laser action are mirrors for what's known as optical feedback. So laser, of course, is an acronym. Light amplification by stimulated emission of radiation. When that happens, there's instantaneous release of the stored energy in one direction, because there's 100% mirror at one end and a less than 100% mirror at the other end of the laser cavity. So let's go into the so-called spatial behavior of laser beams. And this is important because not every laser has a perfect beam. And that's important when you're working inside the eye. So we have what's called the fundamental mode. The mode is the shape of the beam. And when you have an aperture that is small, the beam will have its very central shape, which is more like an ice pick than a sledgehammer. However, you can also change the wave front or the mode of the beam with a larger aperture, and you get a wave front that has several bumps in it. It has the fundamental mode, which is the ice pick at the center, but it also has several other beam modes, and the combination of this gives it much more power, sort of like a sledgehammer. And here we go again, which goes over the spatial beam behavior and the beam profile nomenclatures. The nomenclature that's important to us is TEM00, which gives you a perfect beam wavefront. There are two ways of lasers working. One is called a quality-switched laser, which is better known as Q-switched laser. And the quality switch is more or less the Pockle cell that opens and closes in 10 to the minus 9 seconds, and you get a short, quick pulse. On the other hand, there's also mode-locked lasers. These mode-locked lasers also have a quality switch, but they have an electrotropic modulator that puts the beam front into a series of pulses. So the Q-switched laser has a short pulse. The pulse duration can be 10 to 20 nanoseconds. That's 10 to the minus 9 seconds. And there is no pulse train. The energy can go up to maybe 5 millijoules in our use, and the peak power can go up to 10 to the, let's see what that says, 10 to the 8 watts. The other type of laser, the mode-locked laser, has a pulse train. So the beam comes out in a series of pulses in a time frame of 20 to 30 picoseconds. And so you get 7 to 10 pulses within 25 to 35 nanoseconds. Here we go again on some more laser physics. The beam quality, which is important. Fundamental mode, which is what I usually use in the vitreous. And multi-mode, which has other uses in the eye for, let's say, iridotomies or other functions. What is the temporal beam behavior or the timed beam behavior? Well, we have a continuous wave lasers. A continuous wave laser would be the argon laser, which has a little mechanical shutter, but it's always on. A free-running laser, which is, you can have a free-running laser can also be a YAG laser, which is pulsed. In other words, the laser is on, but there is a shutter in there that gives it a time basis. And then there's the Q-switched, which is quality switched with a fundamental, very precise wavefront. And then there's the mode-locked laser, which has a pulse train. We'll go into that in a second. So this is just a review of the application of neodymium YAG lasers. As you know, we can use them in Q-switched pulses for dissections, perforations, fragmentation. But there's also a thermal pulse that you can use with a YAG laser. I know some companies have experimented with fiber optics, and the thermal pulse of the YAG laser, which you can coagulate the ciliary body from outside of the eye, or at least on the surface of the eye and not penetrating it. So this is interesting. What is the penetration depth of the radiation in tissues? Well, the argon and krypton laser don't really penetrate that much. And if you use the argon laser in the retina, you get a little blanching effect, but it doesn't go through the posterior sclera of the eye. A neodymium YAG laser has a much higher penetration, and that's why we can perforate tissue with the YAG laser. And then there's the CO2 lasers, which we use for cutting in things like blepharoplasties. Many of you have seen this, many of you have not, but if you haven't ever seen a CO2 laser in action, ask one of your colleagues to let you observe. It's worthwhile. So this is just a review of the optical breakdown phenomenon. You have the media, which creates ions plus electrons when the material is lased. The actual temperature can be up to 10,000 degrees, but there's not much heat there. So you have this high temperature plasma, which creates a hydrodynamic expansion, a shock wave, and that is ultimately cooled and gives you the gas bubble phenomenon. So it's the shock wave that actually does the work we're talking about. And you all know this from a capsulotomy. The breakdown volume, plasma shapes. Multi-mode laser has a plasma shape that would be more or less elliptical. Fundamental mode has a plasma shape that is very, very precise. Of course, there's hazards with all this. You can review this at your leisure. Radiant exposure, especially with pigmentation, deposits, turbidity in the media, and it creates problems because you have to increase the exposure. Now that we all have our background in the actual laser physics that you can impress your colleagues with, or your students, or your residents, let's go into some more practical stuff. Contact glasses and their necessary function. I'm not sure every ophthalmologist in training really understands the nitty-gritty of contact glasses. It's extremely important in working in the vitreous because it's the contact glass that allows you to work 3 to 4 millimeters from the surface of the retina safely and 1 to 2 millimeters from the capsule of a phakic patient. What a contact glass does is increase the cone angle of the laser beam profile, and this decreases the beam irradiance when working close to the crystalline lens and the retina, of course. It also shortens the ellipsoid shape of the optical breakdown, allowing you to work within 2 to 3 millimeters of the crystalline lens or the retina. It also decreases the energy needed for optical breakdown. Different lenses are required for the anterior, mid, and posterior vitreous, and I'll explain why in a second. I'm sure every ophthalmologist out there has seen this and maybe has done this themselves. So why does this occur? We never saw this too much with, well, this is a polymethyl methacrylate lens, but PMM lenses seem to be much more, how should I say it, laser resistant than the acrylic and silicone lenses that are more commonly in use now. So I would call this, what you're looking at here, a mistake. I can't judge. We weren't there seeing what was going on. Obviously, there's quite a dense membrane back there, and it required a lot of power, but there are ways of reducing the propensity towards damaging the lens. I always find it interesting that there's all this, what I call medical junk in the medical tabloids about the surface and dry eyes and how that's going to change their vision, but there's no punctate keratitis, but they need to be treated anyway because they're these things that test your osmolarity and all this jazz. And then the doctor, our colleague, does something like this. Well, I'm sure this degrades the image slightly. Nobody's ever measured it. It's kind of hard to actually do, and that would be a weird way of human experimentation. Perhaps some year they'll be able to do it on an animal model. I don't know. Or in a model eye. So what happens is that when we're using the fundamental mode at the focal plane, you can see that the beam radius is much smaller than the radius in a multi-mode at the same cone angle. So which contact lenses to use? Well, the one that increases the cone angle and minimizes the focal spot. We just went over that. This is a good representation of what a contact glass actually does. The black part of the diagram there shows a beam that does not have an enlarged cone angle. And the irradiance on the retina, remember that is power per square centimeters over time, is much greater than if you use a contact glass, which is represented by the lines that are not blacked out. So the same power going in is much more dangerous without a contact glass than it is with a contact glass. We've gone over this again. If you look at the diameter with a contact glass, you can see that the irradiance is much reduced. And without the contact glass, that the irradiance is actually increased and more dangerous. What does a Goldman lens do in the eye? Well, if you make the mistake of using a Goldman lens, and it's not always a mistake, I'll go over that in a minute, the cone angle on the retina is about 11 degrees. If you don't use a Goldman lens, there is a point in the anterior vitreous, about a third of the way back, where the cone angle, due to the actual optics of the eye, is 24 degrees. So you can safely use it in, I'd say, the anterior third of the vitreous if you're good at what you do. Of course, you have to have a cooperative patient as well. And I have done this, but I always prefer using the contact glass. It makes things easier for me. My favorite contact glass is, for capsulotomy, is the Lazag, or rather Hog-Straight CGP lens. We use that for capsulotomies. And I also use it for lasering opacities that are just behind the crystalline lens. Not only does it magnify the image, but it creates a much greater safety profile. I'll show you the problems associated with this in a moment. In the angle of the eye, you can use a special lens. I use this lens for getting behind an implant towards the pars plana. It's a little difficult to do, but with some good expert teaching, it can be done. And it's very useful in younger patients that have vitreous opacities that tend to lodge in the pars plana region, but the patient finds them extremely annoying when they go in front of their visual axis. So what we're trying to avoid is this phenomenon, the ellipsoid beam profile. And that is the optical breakdown picture. And you can see how you possibly could cause damage to the crystalline lens or the retina if you don't understand this well. This is an interesting picture. Fortunately, not one of my cases, but if you look at the slide on the left, there is a tear in the posterior capsule. How this actually happened, I can't say. This was a one-eyed patient. He had ocular histoplasmosis. It was probably one of the first cases of a well-known retina specialist on the east coast of Florida. The patient came to me after he got a bit nervous as to what was going on because his ophthalmologist stopped the treatment and didn't quite tell him what was happening. He just said he felt a little uncomfortable doing more laser. So the patient came to me, and we'll go over that in a few minutes, but I did get the opacity that the patient was complaining about. The laser used was the LX laser. LX is, I think they're still making that model. I find it extremely difficult to use, especially the one with the flip up and down mirror. It's especially difficult working near the retina because you don't have a good depth of field with that unit. If it makes me scared after 20,000 or 25,000 laser sessions, I can't imagine what it's like for somebody just getting into this. And here's another example of damage to an implant, probably because of lack of use of a proper contact glass. So now that we understand the purpose of contact glasses and how they're used, and by the way, if you go in the bibliography, there is a paper by Funkhauser, I believe, that goes into the physics and the optical physics of a YAG laser contact glass. There is a formula in there that you could use. Anyway, let's go over the vitreous anatomy. Well, most of us look at the vitreous all the time, but there's a classic definition of vitreous anatomy. This was done by a book by a well-known vitreous surgeon on the west coast of the United States. He stated it was a hydrated extracellular matrix of water, collagens, and hyaluron. The gel liquefaction results from molecular alteration with dissociation of collagen from hyaluron and the aggregation of collagen fibrils. Patients ask me, well, how does this happen? Why does this happen? Well, if you think about it, we are being bombarded constantly with gamma rays, cosmic rays, X-radiation coming from the sun, certainly microwaves. That's why they have that screen on the microwave oven, by the way. It's to prevent the radiation from escaping. You don't want to put your eyeballs too close to the oven door. You might irradiate yourself. or cause a cataract. Radiation cataracts from microwaves have been a known phenomenon since World War II, when soldiers would go outside smoking their cigarettes and stand in front of these massive radar antennas, which had to use a lot of power back in those days, and they would literally cook the crystalline lens and cause a microwave cataract. That's been known for 75 years now. So the vitreous is relatively acellular, except in the periphery, where hyalocytes reside in the vitreous cortex. And these hyalocytes are important because they're believed by various researchers to be one of the initiating causes of macular pucker or epiretinal membranes. This is interesting. This is from a fabulous book by the late Jan Worst. Dr. Worst did dissections of the vitreous. Well, how do you dissect the vitreous? It's a bunch of goo. So they did this dissection under various hydrocarbons, I forget exactly which ones, and created a stereoscopic textbook of this, where they injected the various vitreous lacunae, as they called them, with substances to delineate them. Dr. Worst actually gave this to me personally when I gave a lecture at I believe it was at the ASCRS meeting in Boston in 2010. If you have an ophthalmic library at your institution, I would urge anyone who's interested to review or actually have the librarian get you a copy of the stereoscopic book. It comes with eyeglasses, like a 3D comic. Remember those? And you can actually see what the vitreous looks like beyond a slit lamp. So, with aging, liquefaction occurs within the vitreous body, and that liquefaction subsequently coalesces into the lacunae. And there's a space, by the way, over the macula called the bursa premacularis. And this is an important thing to know because there are patients out there with floaters in this area. And I will go into how you can find them and diagnose them properly. So, I believe this is from Dr. Siebel. I forget his last name, California. Posterior vitreous detachment occurs as a separation of the posterior hyaloid from the internal limiting membrane of the retina caused by a combination of vitreous liquefaction and vitreoretinal dehiscence, allowing liquid vitreous to enter through a cortical defect into the pre-retinal space. Better known in my explanation to patients as getting water behind wallpaper. It'll just peel off, and then we have the phenomenon of a posterior vitreous detachment. So let's move on to one of the most important things that you will get from this lecture. We all know that we were trained in the greatest of institutions and we're the most brilliant minds in our classes, and we got into medical school and we got into ophthalmology and how lucky we were. But I see mistakes all the time, whether it's lack of interest or the doctor is rushed or the doctor doesn't exactly know how to be a detective. Patient history is very, very important. For those of you who don't know the history of ophthalmology, the great detective, British detective, Sherlock Holmes. The stories of Sherlock Holmes were written by Conan Doyle. Conan Doyle was an ophthalmologist, and Sherlock Holmes was an expert at deductive reasoning. Anyway, so patient history is really, really important because many patients are just not observant enough to articulate anything saying other than my vision is blurred. And this, of course, can result in unnecessary cataract surgery and capsulotomy. I presented this at the ASCRS meeting in Boston in 2010. Whether the small audience took it and used it in their practice or not, I don't know, but I can tell you to this day, I hear this story constantly. Well, I went in, I told them my vision is blurred. One of the people in the office, whether it's one of their optometrists, a technician, or even the ophthalmologist himself, takes a quick peek in, and as everybody seems to be lean and hungry nowadays, says, "Oh, we can fix that. Let's just open this little membrane, and you'll see better." And it doesn't work, and the patient's very frustrated and upset. So the patient ultimately goes around to other doctors. They, too, don't know what it is. They'll say, "Oh, it's dry eye syndrome. Use these drops, da-da-da-da-da-da." And finally, the patient will go into maybe the optometrist at Walmart who will really take a good look and say, "Oh, you got this big floater behind the implant." And then they get to me, and I take care of it. That's the rest of the story. Anyway, standard protocol. I think it's important just to document things by trying to measure the patient's worst vision. Well, how do you do that? You say to the patient, "Can you manipulate your eye and bring this opacity, this blur in your field of vision, and tell me what line you can't see on the eye chart?" Many patients can do that. And it's good to document that. And I just put in the chart, can't do, or I document it. I started doing that probably maybe 20 years ago. I had a patient from New Zealand, and he said to me, "Why do you always try to get my best vision on the eye chart?" This was after I walked in the room, of course, and the techs had done their thing. And my answer was, because that's the way we've always done it. And his statement was, "Well, maybe you should try to get my worst vision." And I said, "Well, let's just try to do that and see what happens." So it's part of my protocol. And you have to ask the right questions to the patient. It's like, "What do you mean your vision is blurred?" "Well, it's blurred when I read." "Is that all the time?" "No, it's blurred when I look down and I read." "Well, what happens?" "Well, this thing comes down from above and sort of blurs the letters, and if I keep my eyes still, it disappears, and I can see clearly again." "Oh, that's interesting. What else happens?" "Well, I'm driving along, and this thing like a windshield wiper comes in my field of vision when I look out of the side view mirror of the car." "What do you mean by windshield wiper?" "Well, this thing goes back and forth, and it's like a blur." I say, "Like a grease spot, or is it very distinct?" "No, it's like a big grease spot, goes back and forth across my field of vision. I have to shake my head or move my eye or blink." So when you blink, what happens? Well, it goes away. Now, to the untrained ophthalmologist, when you blink your eyes and your vision gets better, well, it must be on the surface of the cornea, right? Wrong. Nope, it's inside the eye. "What do you mean you blink your eyes?" "Well, let me look at your cornea." "Well, your cornea is clear." "Yeah, but I use eye drops. I put the eye drop in and my vision gets a little better." Okay, you're moving your eye when you put your eye drop in, and your cornea is actually pretty clear. You might have some little symptoms, but I don't see Sjogren's syndrome with diffuse punctate keratitis or in your cornea at all. You also have to understand visual snow. I showed you in a previous slide that paper, which is in the journal Brain. I have seen patients with this phenomenon before the publication, and they have been to multiple ophthalmologists who give a cursory glance and say, well, you know, you have some floaters there, don't worry about it. That's really a misdiagnosis. There is a video in one of the QR codes that I posted of a patient actually describing, two patients actually describing visual snow. It's not exactly like a psychedelic hallucination, but it's usually like a uniform pattern across the visual field. And I don't know if the younger ophthalmologists will understand this, but back in the day of cathode ray tube televisions, we had a horizontal and vertical adjustment. And if you got the adjustment out of whack, you would have a pattern across the screen. This is very similar to what patients who have visual snow describing. So the typical descriptions of opacities in different locations. Let's go over this again. Let's just reiterate what I was saying. When a patient says it's like a windshield wiper, it's usually something in the mid-vitreous, and it's usually a fibrillar mass. When the patient says it's only when I read, it's usually behind their implant or behind their natural crystalline lens. They look down, and this opacity in the anterior vitreous enters the visual axis for a short period of time. If they say it's like looking through grease, you know, it's usually a big fibrillar mass in the mid-vitreous. And when they say it's very distinct, well, I see this line with little bubbles in it, or I see this thing that's sort of, and I'll say to them, you mean, is it about the horizontal midline? Yeah. They understand what I mean by that. And I say, is it usually maybe 20 degrees lateral towards the outside? Yeah, it always goes back to that spot. Well, that's usually a hyaline opacity due to a PVD, posterior vitreous detachment. And when they say it's a center spot, even in a darkened room, that usually means they have something in the premacular bursa. And I'll go into how you can diagnose that easily without fancy equipment. If you get into this, and I'm sure all ophthalmologists have seen these people, these patients, you get patients under 35. I mean, I've seen patients that are late teens and in their 20s, and they have I'd say a borderline obsessive compulsive personality, maybe a type A personality. And the littlest thing drives them batty. And the usual response is, well, you got an eye floater, nothing can be done about that. Some of these patients are driven so crazy by these little opacities that we would consider little opacities. Or if you were around in the 60s, just another hallucination. Some of these patients actually demand vitrectomies. I've had patients that have gone elsewhere that have had 2-3 vitrectomies because even with a vitrectomy, there's always a little residual vitreous that floats around. And for whatever reason, the way their brain processes their vision, they just can't handle it. And then again, there's the visual snow, which is maybe a temporal lobe disorder. I've gone over this with several neuro-ophthalmologists and neuropsychiatrists, asking what possibly can be done to mitigate this. Nobody's really done a study on this. I've always suggested maybe some sort of suppressant of temporal lobe impulses, but I've never done that myself. So, examining the patient, indirect ophthalmoscopy. I personally consider it marginally useful from a treatment perspective. Oh, you know how it is in ophthalmology. A patient comes in, they're complaining of floaters. They say they can't see, da-da-da-da. You pull out your indirect, you look at the peripheral retina. Everything looks okay out there. You tell the patient, you got a floater, don't worry, it'll go away, or it'll get better. Maybe. Slit lamp ophthalmoscopy is extremely important for examining the vitreous, especially the anterior vitreous body. I personally get a better view through convergent optics. The Hog Straight slit lamp has convergent optics. The Zeiss type slit lamps have parallel optics. Why that works better for me, I'm not exactly sure, but it certainly does from a analysis perspective. I usually use a Goldman contact glass for examination of the mid and posterior vitreous. The Goldman lens allows me to actually not only see what the vitreous looks like, but to see how things move. Not every patient has a posterior vitreous detachment. Many patients in their 40s can get a fibrillar degeneration in the mid-vitreous. If it's bilateral, it's extremely disturbing. If it's unilateral, they can live with it, but these are fairly easy to treat from a laser perspective. I know there's patients who have had vitrectomies, but no matter how you look at it, vitrectomies have a downside for many patients. There's also been some recent reports that vitrectomies cause disruption of maybe the zonules, and in implant surgery, after many years, you can get a disruption of the zonules and a subluxation or dislocation of an intraocular lens implant. But that's another story entirely. So let's go over why are there misdiagnoses. Very simple. It's always due to failure to elicit an adequate history. And you got to be thinking about this. Think outside the box. We have a see one, do one, teach one. Patient comes in, you're trying to move fast and see if you have a underpaid cataract patient in the next room so you can do surgery. So you don't ask the right questions. A patient in their 40s, I got this floater that just appeared, or I got this thing. Oh, you got an eye floater. Don't worry about it. It'll go away. Most get better. Well, you can probably say that to most patients, but there are those patients who that is not the case. The other common misdiagnosis, I'd say the most common misdiagnosis, is dry eye syndrome. I see this a lot after implant surgery. The ophthalmologist, who of course is always one of the greatest eye surgeons in your area or perhaps the state or perhaps the world, has done a beautiful cataract operation and the patient has a complaint. And the patient is seen postoperatively, maybe by one of the other doctors in the office who doesn't do the surgery. Patient states, I blink my eyes and it gets better. Well, you must have dry eye syndrome. Here, use these drops, you'll be better. We've reviewed this in the past slide. Cloudy capsule is another common misdiagnosis. I asked the patient, so you went back, they said you had this. Did your vision get better after they did the capsulotomy? No, it did not. Well, what did you tell them? Well, I told them and they just shrugged me off, or I didn't want to go back to them because obviously they were wrong. And the other misdiagnosis is cataract. You wonder, how is that possible that you could misdiagnose a floater for a cataract? Well, like I said, you have to remember, Half the population has below average IQ. People are not articulate. And they go in, they say, my vision's blurred because of what they've done to our surgical skills in ophthalmology. Ophthalmologists have been somewhat reduced to hustling a lot. They'll see a little bit of a lens opacity and say to one of our undereducated or unaware patients, oh, you've got a cataract, we'll just take the cataract out and you'll be better. And of course, after that cataract removal, it's like, but my vision still gets blurred. Well, I'm out of glasses. I mean, that's okay, but I'm still having this problem. So we get a lot of unnecessary, at least in the people that I see. Of course, this is not the average practice, but in the people I see who come in with this problem, I see a lot of unnecessary surgery. And they're not necessarily annoyed, but sometimes they are. It's especially if they've had a refractive lens exchange, I guess we could call it now, or non-cataract cataract surgery, and they've been talked into a $2,000, $5,000 multifocal implant that gives them the vision that they, when they were 25 years old, or at least that's what they're told, and they come out of the surgery. It's like, yeah, I'm sort of out of glasses, but I still can't read close, and I still have this thing in my vision. And they get referred to a retina specialist or a neuro-ophthalmologist, and the retina specialist, like I said, does angiograms, OCTs, looks, and this and that, and says, your vision's fine. We got you to 20/20 with your new implant, but I still can't see, doctor. Immediately placed in the nutcase category because they're not asking the right questions. And the patients get shuffled around to this doctor, that doctor, and the same practice, and nobody asks the right questions. Then the patient, like I said, goes to Walmart to a knowledgeable optometrist who actually takes the time to look in and says, well, there's this big floater that comes in and out. I can see it when you move your eye. And then they get to me. So when you're dealing with the patients, the most important thing is give them some realistic expectations. I always tell these patients, what I'm going to do is to make things better. For some of you, it'll be perfect, back to the way you were. For other patients, I can read again. Yeah, I got this floater occasionally, but I can read and I'm not totally distracted. For one-eyed patients, it's a miracle. You have to give them an informed consent. It's like, what can go wrong, doctor? Let us discuss that in one of these subsequent slides. So, patient satisfaction. Well, that's dependent on several factors. One is the density, size, and location of the opacity. Obviously, you can have a huge opacity in the periphery, but if it doesn't come in the visual axis, big deal. The other thing is the training, skill, and experience of the operating ophthalmologist. Of course, every ophthalmologist is the gift of God to the public. They went to the greatest institutions, had the most famous professors and teachers, and their diagnostic acumen is always excellent. Well, not always. Let's put it that way. And the most important thing, I think, is the specific model and the method of the laser that was used. There are differences in these lasers. Unfortunately, there are not a lot of lasers that were specifically designed to work in the vitreous. I'm fortunate to have one. There's still some out there. If you have access to one, grab it. Other companies have said their lasers can work in the vitreous. I know that the Helix company was shut down from that promotion by the FDA, who said, you're licensed for a capsulotomy and iridotomy, whatever, but you haven't gone through the clinical procedures to be licensed for the vitreous, so you can't advertise it. Although they can use it. Patients, doctors can use it. There's no prohibition on using anything that we have in our surgical armamentarium. So what is in the informed consent? I think it's important that you actually look the patient in the eye. Don't necessarily gloss over things just to get a case done. It's not worth it. It's definitely not worth it if you oversell something. There is a learning curve, no matter what the famous doctors in Boston stated in their paper. Complications are uncommon, but if you do enough of this stuff, of course, you'll see them. And, there's the old saying, a surgeon who's never seen a complication isn't really doing surgery. But I think with this stuff, if you're good at what you do, just give them a full and honest disclosure. And, of course, that's the best protection from malpractice suits. Document it in writing in the chart. And educate the patient if expectations are unrealistic. I've had patients come into me because they've seen something on the internet. Oh, you can vaporize all these floaters. I have to spend the time and educate them that, well, no matter what you have read, things are not vaporized, and we cannot totally get rid of everything that crosses your field of vision, because the vitreous gel is not like water. And even with a vitrectomy, there's still stuff floating around. So as long as their expectations are realistic, it's easy to proceed. And you can always tell a patient, if we don't get you where you think you'd like to be, you can always have a vitrectomy. One of the reasons patients don't want a vitrectomy, I've been asked this by other ophthalmologists who say, well, they can always have a vitrectomy. It's like, well, you have to put yourself in the patient's shoes. I have many one-eyed patients that I've done floaters on who absolutely will not have an eye operation unless it was life or death, because they know that there's a complication rate associated with vitrectomies. I've also done laser on patients that have had a vitrectomy in one eye and had a complication like a retinal detachment or vitreous hemorrhage. Those things do happen, and you shouldn't gloss it over. Vitrectomy can be dangerous. There are patients also on anticoagulants or may have cardiac issues or other issues that make them very wary of undergoing traditional surgery. Laser treatment parameters, well, that depends on the model of the laser used. I use a Lazog Microruptor 2, which I consider to be the world's best top of the line. And of course, it's dependent on the opacity type. So when you have a simple Hyalin or Weiss ring, better known as a Vogt, V-O-G-T, ring, Dr. Vogt, I believe, was a Swiss ophthalmologist in the early 1900s. There's a fabulous ophthalmic book, if you can get it or view it, called the Vogt Atlas of Ophthalmology. It's all hand-painted stuff. Very, very good stuff. Every major institution with an ophthalmic library should have one. So anyway, with the simple Hyalin opacity, I use a high burst mode up to maybe 8 pulses per shot or trigger pull. Low power is important in these things. The reason you have to use a low power is you titrate the power just enough to get an optical breakdown phenomenon that will start to dissipate the opacity. Some opacities can be dissipated at much lower power. Others take a little more power depending on what they look like. But you use low power so you don't displace the opacity, which is more or less stuck on the posterior hyaloid face. If you displace that opacity, very often it goes behind the hyaloid and can lodge somewhere, I don't know, near the pars plana, and the patient will say, you know, my visual axis is clear, but I still see this thing way, way, way up high or somewhere else. You can go back and get that. You got to jiggle the eye with the contact glass. Ultimately, you can get that. I've had that phenomenon happen to me several times. But the difference between an expert and an amateur is actually getting what you're going after. Retrolenticular opacities. Fascinating stuff. This can be the windshield wiper phenomenon, or can be what's called a floater duet. You have a PVD with the hyaline opacities, and then you have something right behind an intraocular lens implant, the classically described windshield wiper phenomenon. These can be gotten easily, especially in phakic patients. You have to be careful, but you can do it. You have to use very low power. Very often, low power meaning a half a millijoule to maybe 1.5, maybe 2 millijoules. 1 to 3 pulses per shot. Very often single pulses if it's close to the crystalline lens, the natural lens of the eye. And a CGP contact glass, which gives you that big cone angle and shortens the ellipsoid shape of the optical breakdown. Extremely important if you want to go after those things. A lot of doctors are afraid to do that. I'm not. But they have good reason, I'm sure, that maybe their skill level is not exactly at the level it should be, or it can be, I should say. Nobody wants to see a phakic patient with a tear in the capsule. That can happen, and we will go over that again. Midvitreous fibrillar masses and hyaline membranes. These things are tough, and you have to understand that you can't get all this stuff in one session. And there's a reason for that. As you get into the higher pulse levels, I'd say 200 to 500 pulses is what I'd use for something like this, but higher pulse levels than that, with higher power, you get into that gray area where you can get elevated intraocular pressure. We'll go over that later. I always use about 4 to 6 pulses per burst, and you have to tell the patient in advance, this cannot be done in one session. You're going to take 2 to 4 sessions. They'll either want to go ahead or not. And if a patient is reluctant to go ahead with several sessions, let them go. You don't want them going around after one session saying, well, the doctor said he could do this, and he tried, but it didn't work. You don't want that reputation. Pre-retinal opacities, these are the definitely most challenging. And it can occur with a PVD, very often does. You've got to use low power and a low pulse rate, but there are ways of getting these type of opacities. We'll go over that in a few minutes. So, what complications have I observed? Contrary to what you have been told by your chief of ophthalmology in your residency or other ophthalmologists, retinal detachment is not an issue. It certainly has not been an issue in my practice. I've done over 25,000 laser sessions and have never seen a retinal detachment. One of the ways of avoiding a potential detachment, I can tell you, is checking the patient when they come in, especially those with a PVD, with a Goldman lens. Look in the mirror towards the pars plana and make sure there are no retinal tears. One of the dead giveaways of a retinal tear is pigment cells in the vitreous. This can occur with cataract surgery too occasionally, but if you see pigment cells in the vitreous, check carefully for a retinal tear and know how to seal them with laser. A patient doesn't want to be told, oh, you have to go to this doctor, you have to go to that doctor. It's like, what's the matter? Can't you do that? Well, of course you can do it if you're an ophthalmologist and see one, do one, teach one. It's not very difficult to seal a retinal tear with an argon or another green type of laser. This can avoid problems. And if you have a retinal detachment that you've not detected, or retinal tear, and then it develops into a real detachment after laser to the vitreous, of course, you're going to get that bad reputation that look what he did to this patient. It's going to be all over town with your colleagues, and the patient's going to blame you too. So be careful. Back in 2012, Dr. Feke Gebrandi in Amsterdam, and Dr. John Karakoff, who chose not to be named in this, presented a poster on complications. You're welcome to go over this at your leisure. You can see what my experience was. No retinal detachments. Elevated intraocular pressure is the most serious thing that you might see, at least in my practice, that I've seen. So knowing how to avoid that's very important. So elevated intraocular pressure, this can be very serious. Very serious. The last thing you want is a patient coming in for a simple opacity and having a potentially blinding procedure done. So what do you have to be concerned about here? Well, definitely pseudophakics with open capsules and vitreous prolapse. If you see vitreous prolapse after somebody else's capsulotomy, and there's a communication between the vitreous and the anterior chamber, it is definitely a risk factor. And what you have to do is modify your technique. Maybe instead of going in with 300 to 500 pulses, you'll go in with 100 pulses. This can occur in any procedure with more than 600 pulses per session. When you get up to that level, you have to be extremely, extremely careful. Elevated pressure is from unknown causes. Nobody's been quite able to explain why, at least to me. There's been several theories, and I'll go over that in a minute. If you do excessive laser in phakic patients for retrolenticular opacities, phakic patients, you can get an elevation of intraocular pressure. So what else can cause elevated pressure? Well, if you have a floater patient with a pigment dispersion syndrome, and you should always check for that in these floater patients, elevated pressure, this is definitely a risk factor. You have to modify your treatment. Treated glaucoma, or a so-called glaucoma suspect, be careful. So how do you have to be careful? Well, it's very simple. First of all, always take the pressure in both eyes. Always spot check your staff. And certainly be able to do glaucoma surgery. Not necessarily, but you want to be able to take care of your own problems, and you don't want patients running around town bad-mouthing you because you caused bad glaucoma. So when I say take pressure in both eyes, why would we do that? That's because one eye serves as a check on the other. I will spot check my staff occasionally, especially if a patient that has been known to me has pressures in the low teens range, and they get a pressure of 20, or vice versa, a pressure in the high teens, and they come in and the pressure is 10. It's like, well, wait a second. Who is wrong here? Let's recheck this. And why do we do it in two eyes? Because one eye serves as a check on the other. So if you have a patient come in and they have a pressure of 24 in one eye for their initial examination and 9 in the other eye, you better understand if that is a real number or not. Because if the 9 is in the operated eye and it should be a 20, and you get a pressure of 30 after your laser procedure, well, that's not very good for you or the patient. I also have a case that I reviewed. I was asked to review it. A very, very well-trained retina specialist, Wills Eye Institute, a curriculum vitae with a bunch of papers, obviously an intelligent guy. I assume it was one of his early cases. Had a referral from an ophthalmologist that was treating glaucoma in this patient. The patient in the medical record had an implant with a capsulotomy that had vitreous prolapse. The patient went in because he had, I'm not sure what kind of floater. I never talked to the patient. I just reviewed the record. Patient had probably a windshield wiper type of floater behind his implant. Who knows? That doesn't matter. What matters is that the operating ophthalmologist, this educated, well-trained guy, put in something like 900 pulses at 6 to 8 or 9 millijoules per pulse. And I understand how you can get wrapped up in it. You're shooting the laser and it looks like it's doing a thing and you just keep going and going and going, which is not the way to do it. In any case, there was a secondary thing that went on with this patient that was not recognized by the doctor. The staff was using a tonneau pen to measure his intraocular pressure. The patient went in with his normal pressure. He was being treated for elevated pressure with some medication. Went in for his initial examination. The tonneau pen pressures were consistent with what the other doctor had. The ophthalmologist did his laser thing and told the patient to come back in several weeks. Well, I can understand that. You get busy with your injections, you did your thing, you think it's like a capsulotomy, and it's like, well, no problem here. Come back in a couple of weeks. The patient did call on the telephone and spoke with staff and says, everything looks gray. And the staff said, well, you just had an eye procedure. Of course, everything's going to look a little blurred. I think it was a little more than blurred. The bottom line is he had a pressure spike that was blanching out his vision like any acute elevated pressure spike can do. So when he went in for his next visit, the staff used, and I forget if it was, maybe it was a week or maybe it was 3 weeks, the staff used a tonneau pen. The ophthalmologist, I'm not sure if he asked the right questions, but he, breezed in, breezed out, saw normal pressure, probably thought this blurred vision was still the floater that the patient came in to have treated, and sent him out again and had him come back in a couple weeks. Well, in a couple weeks, the patient still had very decreased vision, almost destroyed vision. The staff took a pressure with the tonneau pen, noted it in the eye chart. The pressures were normal. I'm not sure exactly what the operating ophthalmologist saw, but he took a little closer look finally. He might have seen some microcystic edema, who knows. But he took a pressure with a Goldman applimation tonometer. The pressure was like 45 or 50. And of course, the staff had been measuring it wrong with the tonneau pen. I don't think they were doing both eyes. Maybe they were doing both eyes at the time. I forget off the top of my head, but it was wrong. They were measuring it wrong. The doctor was assuming that the staff was doing it correctly. It didn't ask the right questions of the patient. And basically, the patient was blind, and it came to a legal suit for the unfortunate patient. This could have been totally avoided by understanding what you're doing and the risks. So here's a general rule that you can use. First of all, make sure the intraocular pressure you take is absolutely 100% accurate. Aside from a few staff members who I will spot check, I have total trust in my more experienced staff. But if I'm concerned, I might just recheck it myself and make sure that it's within the range, or if I see a disparity between the two eyes. Why is this disparity, 10 in one eye, 20 in the other? Let me recheck this. That's possible that there can be. But if you have a pressure that is above 5 to 7 millimeters of mercury, above the baseline that you know is accurate, that's a red flag. This is, of course, in the post-op visit, by the way. Don't go back and do more laser on that patient. The patient may say, well, I still have this thing. It's almost gone, or it's partially gone, and we got to do some more, and da-da-da-da-da-da. Don't succumb to what the patient wants. And understand also that intraocular pressure elevation can lag by 24 to 48 hours. I have seen that. If you have a patient come in with more or less relatively normal intraocular pressure, let's say they came in with a baseline of 15, 17, 18, 19, maybe 20, and they come back after your procedure and they have a pressure of 25, 27, just tell them you have to hold off. Most patients with elevation of pressure will spontaneously go down to baseline, but it might take several weeks or several months. If the elevation is not pathological, you can just have them come in and observe. Let's just check it again. I can't do more laser. It's not good. I would advise anybody not to mask the potential for elevated pressure with medication. If you have a patient come in and you're doing excessive laser and you know it's excessive, say, maybe we should put a drop in here. You might be masking the result, and so when the patient runs out of his drops, or just say, use this for a few days. If you masked an elevation of pressure that pressure will return to its elevated level, and you can get into some real problems. And they're not your problems, they're the patient's problems. So you need to be thinking about that all the time. I do have to say I did have a patient that was from out of town, came in. I did not do what I considered he was a pseudophakic, did not consider what he had excessive laser. But he called me a week or two later, and he said, everything looks whitish. I said, what do you mean by that? He said, it's like when I used to wear contact lenses and I would overwear them and things looked a little hazy, like a fog. Well, those of you out there who have worn contact lenses or overworn them yourself, you know exactly what we're talking about. They have a little corneal edema there. They have a little microcystic edema, maybe. I said, if you can't get back here, he was on the east coast of Florida. I said, who have you seen over there? Have you ever been? He said, well, I don't want to go back to the other ophthalmologist. I have an optical shop down the street. I said, that's fine. Go in there, have them take the pressure, have the doctor call me first. Well, the optometrist did call me, or I called him first. I said, use an applanation tonometer. Don't use a puff tonometry. And just get me an accurate pressure. So the pressure was like, I don't know, something like 35. It was scary because I didn't think this patient had any risk factors that were problematic. I did send him to an ophthalmologist who was a younger associate of the prior doctor that he went to, just opened a new practice. I told him, I said, listen, we got to get the pressure down first. Give him whatever carbonic cosopt, anything to increase uveous scleral flow, and let's see what it goes down to. But he did one thing that worked that I had not done before. He said in his studies of this sort of stuff that it was possible there could be an inflammation of the trabecular meshwork. And he said, I'd like to place him on a high dose of topical steroids, prednisolone acetate, 1%, 6 times a day. Let's see what happens. Well, he actually did it. He did it for a week or two, and lo and behold, the patient was off the anti-glaucoma drops and back to normal. That was the first and only patient I've seen that had that result. If you ever have elevated pressure, you could probably try that yourself, and if you do find that it works, give me a call. So, let's see here. Here's another way to avoid complications. If you see pigmented cells in the vitreous after one session, there's 2 possibilities. You might have missed a retinal break initially. So reevaluate with a Goldman lens. And if you do see a retinal tear, maybe that you induced, laser it yourself. Don't scare the patient. It's not hard to laser these things. Just be fastidious about it. So, crystalline lens strike, this is serious stuff. I've only seen 2 patients in my career with a crystalline lens strike. It was not an actual strike on the lens itself. I think the shock wave caused a tear in the posterior capsule. Interestingly enough, when I had this capsule tear, I sort of took a deep breath. This was when I first started doing lasers. I called a more experienced ophthalmologist who was in Miami. I said, this just happened. What do you think I should do? Well, he said, put the patient on an atropine drop and tell them their vision might be a little blurry tomorrow. He said, but that lens is going to turn totally white. I thought, holy crap, I'm in trouble now. Anyway, the bottom line is that that did not happen. The crystalline lens, or capsule strike, I should call it, actually created some Elschnig spheres locally, and the whole lens was not opacified. And when you think about it, those of you who have had a lot of experience out there, you've seen patients that have had maybe a sharp pin or a small nail hit the lens of the eye, the natural lens, and they have an opacity where this disruption of the capsule was, but the rest of the lens is clear. So don't panic too much. Just maybe tell the patient if they ever need cataract surgery to have the surgeon really look carefully at the lens of the eye and be careful when he does his phacoemulsification. You can also have a retinal thermal burn. This is interesting stuff. Let's go to the next slide. A thermal burn in the retina is just like a thermal burn anywhere else. It'll cause a little blanching of the nerve fiber layer. And if you see that, that means you're working with too high power or too close to the retina. The other thing that you can have is a retinal or choroidal hemorrhage. This is not caused by a complete strike on the retina. This is caused by residual infrared radiation that is absorbed by the choroid, and the choroid will bleed. And I'll show you a video of this a little later. It will cause a red spot in the retina. And you can see from these two slides here, the hemorrhage spot gradually dissipated. In this particular case, the patient never noticed anything. I've had a case where we did a fluorescein angiogram, showed virtually nothing. The patient stated he never saw anything, did visual fields, et cetera, which is good. These things occur usually when you're off axis when I say off axis, I mean in the periphery of what you can see with the contact glass on the eye. So when you're doing a laser in the periphery, don't forget you're not getting, especially with a patient with a normal crystalline lens, in a phakic patient, you're not getting a completely perfect focal point. So when you don't get a completely perfect focal point, you are getting only a partial optical breakdown. When you get a partial optical breakdown, you are getting a thermal pulse to the retina. If you see a thermal pulse to the retina, you will see very often a spot like this, or a frank vitreous hemorrhage, and I'll show you an example of that later. When that happens, lower the power or don't work so close to the retina to get this opacity that you think you can get, but can't. So let's review some videos and some selected cases. Okay, this is Dr. Scott Geller. Again, this is our little interlude on some videos of some interesting cases. Now that all you colleagues out there know all the basics of laser physics and contact glasses and parameters and how to avoid complications. Let's look at some interesting cases that I've done. And this is not complete. I have so many more interesting cases, but I don't want to bore you. So let's look at this first case here. This is fascinating. I'm going to start the video right here. We talked about the premacular bursa. The premacular bursa is a little potential space. It's not there with the PVD. It's before the PVD. But the patients coming in with a premacular bursa floater have a very distinct description. They always describe it's like a little round dot that floats within the central 20 degrees or so of their visual axis. They can see it in the dark. They can see it in a subdued room, subdued lighting, and it is driving them absolute crazy. One thing I've noticed is that a lot of the patients who come in have had LASIK. They said it started right after their LASIK. Having done many LASIK myself back in the day, I believe that the suction ring that is placed on the eye changes something with stuff that may be in the periphery by the pars plana and literally sucks it back to the premacular bursa because it does not originate there. So here, let's go over this laser here. There we go. See that little dot moving? A little dot moving right there somewhere. Where is it? You'll see it floating by. There it goes again. It's just a little dot. You have to diagnose this. You can't see this on ultrasound. It's almost impossible. At least in my hands, it's been impossible. And I know CT, and maybe you'll see something. But the bottom line is, if you are very careful with a Goldman lens and you listen to the patient and look for it, you will find it. Unfortunately, I think these are impossible to treat, at least with the laser I have. It's just so close to the retina. It's 50 micron, 100 micron floater sitting 100 microns from the retina. Well, I wish I could do more for these people, but I have to disappoint them and tell them nothing can be done. I've had one patient who was 40 years old. The oldest I've seen with this is probably 40 to 45, something like that. Came all the way from Europe. I think he came from Poland. He was very, very disappointed because his doctor told him, well, you have floaters and they're in the mid-vitreous and this guy can treat it. Unfortunately, he didn't look closely enough, because if he looked closely and listened to the story, he would have been able to find this himself. Here's another interesting opacity. This is a hyaline opacity close to the retina. Look at this. When you can see the retina vessels very clearly in your field of view, you know it's close. These you treat very carefully, and one of the tricks of treating this is put a few shots anterior to the opacity and see how easy it is to get close to it, and maybe even shift it by hitting the vitreous, above or below to see if that changes its mobility. But you can see here, I'm probably using, I think I was a single pulse with the laser, not multi-pulses, because multi-pulses, when you don't get the optical breakdown, or if you don't, you can get that thermal burn to the retina or a retinal hemorrhage. I'll show you that, but look how tiny these pieces are. This is an attenuated video, by the way. We edited this to show it down, but you can see, let's go back here again. You can see that it can be done. It can't be done in the time of this visit, or this video. Sometimes with an early PVD or an incomplete PVD, these things occur. Sometimes with a complete PVD, it occurs. So just be patient. Do like I said, use single shots. Maybe throw in a few pulses anterior to the opacity to see if you get a proper optical breakdown. And as I said in the didactic part of this lecture, you can work 3-4 millimeters from the retina, maybe less. I can't say what that is, but it's definitely less. And you can see how the particles are dispersed. You have to go after these little dispersed particles, but you can get them. Look at that little tiny thing's probably 50 microns. Interesting case. This is a fascinating case. This is a membrane behind an implant for a patient with one good eye. He was told he should have a vitrectomy. The patient was about 80 years old. He had some cardiac issues, and the anesthesiologist at the hospital said it was too big of a risk for him to have a vitrectomy or whatever. But so anyway, he came to me. Start the video there. But look at this membrane. I'm not exactly sure what this is. The referring ophthalmologist never quite told me what it was. But if you look at this carefully, what I'm doing is cutting a window in this membrane. This laser procedure was done over several sessions, by the way. And it's shortened here. But you can see what I'm doing is creating a window. And this can be done. The patient had no complications, and nobody has really told me what they think this is. If somebody out there does have an idea or has seen this before, please give me a call and enlighten me. I'm always in a learning mode for what I don't know. I don't claim to know everything, but I know I did this. And I know the patient was happy. Look at that, a clear window. There was some stuff behind this membrane. I don't have the rest of this video, but this is a happy patient. To him, it was a miracle. This is a classic Highland opacity. Let's start the video there. It's actually more central in the visual axis. Sometimes these things, are by the optic nerve, but when they come centrally, this really, really is disturbing to a patient. This looks like a post-implant patient. Remember, when you go after these things, you can see little particles going off. Don't hit it with very high power. Hit it with low power, because if you dislodge that piece, and I believe I did dislodge that piece in this particular video, you will have to go back and search for it. So you can see that big piece is, I dislodged it, I think. Then you go after the little stuff so the patient doesn't say, well, I see a zillion more floaters. My other doctor told me it just breaks it up into little pieces. Well, of course, it breaks it up into little pieces. Obviously, we know that. The bottom line is what separates the real experts from the amateurs is the ability to go after the other stuff and clear things up. Things like this take more than one time. The surprising part about this is when I initially saw this patient, I looked at it and said, oh, well, this is an easy deal. And then when I got the patient in front of the laser, because I initially examined them with my hog straight and the Goldman lens, I saw this other opacity. Let's go back here. Let's go back here, okay? There we go, going after the Highland opacity. I'm getting it. I know I'll get this. I'll get all of it. And then I shifted my view a little bit. That's pretty close to retina there. But the patient's description wasn't exactly, I do remember that. It wasn't exactly like, well, there's this very distinct C-shaped looking thing slightly in the periphery. So at the laser, the view is a little different. All of a sudden, I saw this thing, this big fibrillar mass in the visual axis. And it's like, do you see something that looks like a vertical bar, vertical fuzzball Patient says, yes, I do. Yeah, that's what I'm talking about. He's like, oh, okay. Oh, I got it. I'll get it. It was a surprise to me. And these surprises can happen when you are not totally cognizant of what the patient is talking about. The end result is we finally did get it out of the visual axis. This definitely took 2 or 3 times, if I recall correctly. And this little haze there, that's not bothering the patient too much. Fascinating case, if I don't say so myself. Let's go here. What do we got here? Oh, this is one of my MD patients. I call this the donut implant. This patient, I had done floaters in him previously. This is very fascinating. I'm going to stop this for a second. Hold on. Stop it for a second. This patient had floaters done for me previously. He was a neuropsychiatrist from Baltimore. He was a great patient. He was talked into this lens because it was going to give him distance and near. He had radial keratotomy previously. He had floater laser by me previously. I don't think he had much of a cataract, to be perfectly honest. He was in his early 60s, I believe, mid-60s. They did a capsulotomy on him. And after the capsulotomy, he was extremely bothered by a capsular tag, let's start this again, right behind the implant. And you can just see it right there. There's a little string hanging down there. This was extremely difficult to get. Now, here's the interesting thing. Look at the implant. Let's go back here again. See that little white spot? Let's go here again. I'm trying to get just, there we go. There's a little white spot above the aiming beam. So I'm trying to get this opacity that's moving in and out of his visual axis, but it's right behind the implant. And I'm trying to do it without opening the capsule further. The cone angle of the beam, which of course is increased with the contact glass I was using, has caused some damage to this donut lens. The infrared energy is absorbed by that black surface, and it's caused it to blanch a little bit. You see that? There we go. That was surprising to me because I'd never seen anything like that before. Let's do it again. There you go. There's it. Okay. At this point, I decided, well, maybe we need to do a capsulotomy, a little enlarging the capsulotomy, which I did. I asked him if he had a lot of glare from this thing, and he mentioned yes, he did. So we enlarged the capsulotomy so I could get the opacity in that empty space. And it was a little tough. I've used several different contact glasses with this. There we go. We're behind the capsulotomy there in the space, and I'm just cutting the supporting strands. But you can see there's a little ding on the implant right there. That little whitish area. There we go again. This was a tough one. There we go. But I got it. You can see the capsular tag moving in and out of the visual axis. I'm just trying to cut its supporting strands. If I can get those strands that support it and keep it there, he will be happy. And indeed, I did. So this was a unique case with this type of implant. Let's go to the next one. Oh, there we go again. Hold on. Next case. What have we here? This is another one, another case where you have a capsule tag. This was interesting because the patient thought they had a floater, and this was an articulate patient saying, you know, I've got this thing that floats in my field of vision in the periphery. I'm saying, well, that's right up my alley. I looked in there, and sure enough, the patient had had a capsulotomy elsewhere. and this big tag of capsule was floating right there behind the implant, in and out. Of course, I thought it was a floater. It's not really a floater. It's I guess I call it a flap of a capsule. So what we did here was actually make the correct diagnosis. It's not a floater. It's something unusual with a capsulotomy. I can tell you that I have rarely seen something like this. I can't remember when I saw something that waved in and out of the visual axis like this, but we got it. See that? Enlarged capsulotomy. I've done this enlargement of capsulotomies in a lot of patients, especially when they have capsular phimosis of the anterior capsule. If you enlarge that anterior capsule phimosis, it creates a little donut which falls in the anterior chamber. I've had patients, I did it 10 years ago and it hasn't done anything to their cornea, but they're happy patients, gives them more light at night especially. So getting that out of the visual axis sometimes is a little tough. You shoot the laser just peripheral or above the opacity, get it off of the premacular bursa fibers or whatever's holding it up there, and it'll drop down and be pretty unobtrusive. This is another interesting case, a happy patient, but I have a hard time getting that out of the visual axis there. But you did. Might have taken 70, 80, who knows, maybe 90 pulses, I don't know. Those are all single shots. There we go. Come on, floater, be gone. One of the tricks you can do if you're worried about working near the crystalline phakic lens, the crystalline, is when you do a capsulotomy, instead of aiming directly at the capsule, maybe start a little deeper in the vitreous and see how close you can get before you cause a tear in the capsule. In fact, I would actually advise anybody who wants to work with phakic patients to maybe try that on their capsulotomy patient. I don't think it's really experimenting. It's just doing a capsulotomy in a different way to see how close you can get before you cause a tear in a capsule. So this did take a little while, didn't it? Yeah, we finally got it. There we go. It just wants to stick there. So don't let the patient go home with that thing. They'll think you didn't do the job right. Get it out of the visual axis, no matter what it takes. There we go. Gone. Patient was happy. Doctor was happy. Let's go to the next one. What have we got here? A lens strike. Remember I told you about that patient that was done by a famous retina surgeon on the east coast of Florida. This patient had a strike on the crystalline lens, but the interesting part is he had ocular histoplasmosis. Those are histoscars. And his floater was very posterior. I think the doctor was inexperienced, but he couldn't get something that was mid and deep vitreous and somehow hit the natural lens of the eye. Fortunately, that patient did not develop much more of a cataract. He just developed some Elschnig spheres. The reason he came to me was after the doctor was a little nervous and said he wanted to hold off putting more laser in. His other eye had a macular central histoscar. So this was essentially a one-eyed patient. One-eyed patients can be extremely disturbed by floaters, especially if the opacity is in the visual axis. There we go. Anyway, I got it. Let's go to the next one. Micro opacity. Sometimes opacities can be really small. They can be near the retina, and they're very disturbing to some patients. Who are we to judge? Let's see what we got here. Start that up. There we go. So that's very close to retina. This is a patient was initially done elsewhere. It's speeded up. You can see by the aiming beam rotations. A patient had a Weiss ring type opacity done by a retina specialist up in North Carolina, maybe it was South Carolina. In any case, he told her he could not get this. And this was closer to the visual axis than her original hyaline opacity, very close to retina, very visible. These are tough to get. You got to be really careful. This was a single shot. Move the contact glass to make this thing come a little further forward. Things move in a pendular fashion. And ultimately, by cutting some of the invisible vitreous fibers that are keeping this keeping this opacity in its place, I got it. But like I said, you see the vessels back there, very close to retina. This thing's very mobile. You got to be very careful and know the limits of your laser. But you can see I'm actually cutting one of the fibers that's holding that round opacity. And ultimately, it moved a little further forward from where I was. I couldn't put the power on it that I wanted to because of its proximity to the retina. There we go. I'm cutting the fiber to get it closer to me. And this is a little speeded up, like I said. There we go. I cut it in two. Now we have to go after this thing. Anyway, ultimately, it did come a little more anterior. There's part of it. And there, bam, got it. This is fascinating stuff for me. I love doing it. And maybe you will too. But you have to take your time. Don't rush things. If you think this is going to be like a capsulotomy, it most definitely is not. Take your time. Don't rush. And devote the thought process you need to get the job done. Let's see the next one here. This is a good one. Okay. This is a good one. There we go. Let's go back here. There we go. I'm going to stop that. Let's go back to the beginning of there again. You can see right there, I was working close to the retina on this one little opacity that had escaped me from a previous session. The laser was slightly, maybe off axis. It was near the superior arcades, I believe. And I probably was using maybe multiple pulses, which creates more thermal energy to the choroid. And let's do this here. There we go. See that? I got this vitreous hemorrhage coming right down the retina there. This is when I take a deep breath. And there we go. Let's stop the video right there. You can just see a little stream. And what you do is, what I do, is put a lot of pressure on the contact glass. When you do that, the flow will be mitigated somewhat, and it's not perfectly, there we go. The flow is decreased, and the interesting thing about this is the patient never noticed anything, didn't notice what you typically would get with a vitreous hemorrhage. I just told the patient I had to put pressure on the eye because there was a little capillary that was oozing. I didn't scare the patient. I didn't say to the patient, oh my God, what's happening here? I just kept my cool, put the pressure on the lens. And by the way, you take off the contact glass very carefully because when you take off the glass, you'll be putting negative pressure. And if there is a nice little clot that sealed the retina, you don't want to disrupt that. So ultimately, patient came out just fine. And my cardiac status was okay as well. But isn't that fascinating? I stopped the session then. I told the patient, I looked at him at the slit lamp again. I told him to stick around, brought him out to the Hogstrite slit lamps, and looked at it gently with the contact glass. And this is all, they looked the same. And I knew this would heal up. Saw them in a day or two. Patient never noticed anything. And I said, we'll get the floater. Just let's wait a week or so. What have we here? Next slide. There we go. Retro implant. Let's see what we got here. This is behind the crystalline lens. You can see the shadow of the lens right there. Hold on. Let's go back to the beginning again. There's the crystalline lens. You can see the phantom, as we call it, the phantom of the lens, and the opacities to the right of it. There we go. That is what you see, these giant masses, very, very, very disturbing to a patient, extremely disturbing to one-eyed patients. You've got to go very slowly. Excessive laser in this particular area of the eye, even if you can get the opacity, can cause elevated pressure. Let's go on here. This was tough. This was a tough one. It's speeded up a little bit for brevity, but just cutting these floaters that have these Christmas tree-like decorations, and they're very thin and skinny, is very difficult sometimes. And in this case, I'm using, I think I'm using my CGP, the capsulotomy lens that I use, just to go after it. This took more than one time. There we go, split it in two. Once I split it in two, I knew we had some more mobility here, and just continued the case in a day or two. There's no reason to rush this. There's no reason to get it all at once. Just tell the patient we have to continue. There we go. Fascinating. So in these cases, you also have to be very careful. If you can cut the supporting strands and it drops out of the visual axis, stop there. What can happen with these cases, especially when they've had a PVD, which is the usual situation in most cases, but not all, is that if you do excessive laser and you break the hyaloid, this opacity, which is now way posterior to the natural lens of the eye, can go further back, and they always seem to float in the area of the fovea. Let's look at that again. I started here. There we go. That's starting at the beginning. But there we go. You got to be careful with these things. You don't want to cause a lens opacity. Single shot CGP lens. Sometimes I'll use the Cataract 20-degree lens to get it at an angle. I remember this case. This was difficult because her vitreous was very liquid, so this thing was in and out of my gun sight really, really fast. So just getting it out of the visual axis is enough. You don't need to do everything on these things. It can lead to more problems if the opacity goes in front of the macula, the fovea area. You can see I split it in two. Now it's going to go a little further back in the vitreous. Something that's mid-vitreous is not nearly as disturbing, especially with a small pupil, as something that's right behind the crystalline lens. Fascinating case. Patient was happy. That's the bottom line. There we go. That's more posterior. Still there. Happy patient. Don't push the envelope. Let's go into, where are we here? Next one. Another case close to retina. How do you do it? Very carefully. Small pupil, phakic patient with a small posterior subcapsular cataract. Very close to retina. By the way, I always tell patients if they have a cataract in their eye, sometimes they're not diagnosed. I mean, when I say cataract, something like that, I tell them, I say, you know, you have a lens opacity, you should know that. If nobody ever told them that before and then subsequent doctor sees that, I had a patient that went to Johns Hopkins, the great Wilmer Eye Institute, and he had a known epiretinal membrane. I did his floaters, but he was going in for a routine exam. Went to one of their great professional academic ophthalmologists, and he told them he had laser. He said, well, the laser must have done this to you. Well, the patient was really not quite upset because he knew it was pre-existing. And he said to the doctor, you know, I've had this for a while. And of course, I actually called the doctor. I said, you know, laser does not do this. If you really want to know about it, I'll send you some videos or tell you how to do it. But the problem in some academic circles is that they think that they are the end of all knowledge. They have a lot of knowledge, we know that. They write papers, et cetera, but they don't know everything. And if they haven't seen somebody really doing this who knows how to do it, they have some preconceived notions. They think, well, it doesn't work. It breaks up the floater, da-da-da-da-da-da. Well, of course it breaks it up. That's why you have to go back. So you can see this is very close to retina, very close. That can't be more than a few millimeters from retina. But if you're careful, you can get it with the right laser, the right technique. And you can see I'm jiggling the eye a little bit. Every time I jiggle the eye, it lets the opacity become more anterior because I'm trying to cut some supporting strands of that opacity. We got it, though. There we go. Just be careful. And if you have an opacity like that, don't shoot over the fovea, because if you get a thermal burn to the fovea, you will have a partial blind spot, which I have never had, but obviously it can happen. I did have a case of a young patient who had a peripheral opacity. Trying to get it did cause a bit of a thermal burn to his retina. Although that was way peripheral, he perceived it as a slightly blue spot in the periphery. It was very upsetting to me. I just refunded his money and said, you know, I'm sorry about this. That might heal up with a little time, but I can't do anything about it right now. Nobody likes to see complications, especially in cases where they're young patients. This patient did say that he was suicidal, not because of what I did, but because of the floater. And very often you'll find patients like that that just cannot deal with it. I went after his opacity because I felt I could help him. Let's go to this one here. What do we got here? A hyaline membrane. This is interesting. This patient has a partial macular opacity, if I'm not mistaken. Macular cyst there. That's why I'm focusing on that. Tell the patient, listen, you've got this issue with the retina. But this is an interesting thing. You'll often see this. This is a hyaline opacity. It's a thickened hyaloid. You can see a Weiss ring type opening there. And if you ask the patient, well, what does it look like to you? Well, I see a little clear spot that moves in and out, but it's always blurred. Treating this is slightly different than the typical floater. What I do in cases like this is actually split the hyaloid, which is not a good idea in the average fibrillar mass, because when you split the hyaloid, you get a little spit of fibrils that can go through that little opening, and they always fall in the macula. So in this case, I did split the hyaloid. The vitreous was obviously liquid, so they didn't have any of those fibrils going. So I chose this case carefully. I explained to him what we were trying to do was we're not going to remove or vaporize this. What we're doing is opening it. And these two edges of the hyaloid will retract medially and laterally. He will have a clear visual axis in the center and will be a happy patient. A lot of doctors would do a vitrectomy. There was a reason he didn't want a vitrectomy. I forget exactly what it was, but it was a legitimate reason. And he was glad he found me. And so was I, because I enjoy doing this. This is really, really exotic stuff. It's much more fun than cataract surgery or making a lot of money doing multifocal implants. This is challenging stuff. It challenges me. You can see how the sides have retracted. This is a speeded up video. That might be the third or fourth session. And this cannot be done in one session. And there I'm going after a little bit of the hyaline opacity there. Break that up a little bit, just like you would a normal Weiss ring thing, and get a happy patient from this. Fascinating, isn't it? Since you have this whole video, you can go back and review the slides yourself, start them and stop them, see the whole thing. So I'm just increasing the opening there. There we go. It's not as easy as it looks. Like I said, this takes more than one session. But it is very satisfying. Pretty amazing. There. There's a lot of stuff there, but the patient doesn't care that there's stuff. They just want to see clearly. By the way, with amblyopic patients are very grateful, but I have seen patients with amblyopia and a floater in the amblyopic eye. And as crazy as it sounds, that floater disturbs their visual perception in their good eye. I don't know if anybody's ever reported that in the literature. I've observed this. You'll see it too if you see a patient like that. They get background interference. It's like background noise from tinnitus. You know, it's just disturbing. So here we go. Got that guy. Look at that. Patient is better and happy. There it is. I might have done more laser, but for the sake of this presentation, I just keep it brief. But you can see there's a clear visual axis, or much clearer visual axis, I should say. Let's see this one here. Next slide. This is fascinating. Asteroid hyalosis, excuse me. Asteroids are fascinating. In some patients, like this patient, you can get asteroids that are in clumps and streaks. I'd say I've had 50-50 successive visual improvement with this. When you have these asteroids and there's clear areas, most patients don't notice asteroids very much. But let's go back here again, do this. Most patients, but if you go after these clumps, and you can dissipate them somewhat, they'll still have the asteroids. You can't go after these little spots. In fact, sometimes the clumps are broken into little spots. But if it's a disparate, diffuse thing, the patient is a happy camper. The other thing you need to know about asteroids, usually you see them without a PVD. They're just diffuse throughout the vitreous. If you have a PVD with asteroids and you break the hyaloid, you will not have a happy patient, because the asteroids will go behind the hyaloid, and rather than having a diffuse little shadow or whatever they perceive, they all of a sudden see more stuff because the asteroids are right against the retina because you broke the hyaloid. So be careful. Be careful with this kind of stuff. Let's go this one. This is fascinating here. What do we got? This is a well-suspended floater in a phakic patient. They're usually in their 40s or 50s without a PVD. You can see the supporting strands, and they've got this large opacity. Well, the bottom line is, don't necessarily go after the large opacity. Go after the supporting strands and see what happens. Now, this always takes several sessions, but if you get this out of the visual axis, the patient will be a happy camper. Something like this in the periphery is no problem to the patient because they know the downside of having it in the visual axis. You can see it's already moved a little bit there. There we go. There's a little more there. Just go slowly. This is going to take more than one session. Cut those supporting strands, and you will have a happy patient, a happy phakic patient. Oh, there we go. Don't dislodge it too much. You don't want that to go in front of the fovea. There we go. Don't sweat the little stuff. There we go. Cut those strands. Happy patient, happy doctor. Very good. And I think that will conclude our presentation of these. Anybody who looks at this stuff and is interested in some pointers, do not hesitate to give me a call on the telephone. I'm happy to share this knowledge, and I hope everyone has enjoyed this. I know this has been a very long session, but it is very complete. And review those laser physics and impress your colleagues. So this is Dr. Scott Geller. Let me see if this is over. No, we've got a little more there. Let's go into what I've done here. We'll watch the whole video here. It's still stuck there. When you see something like this, don't continue more than 500 pulses. You can get really wrapped up in doing this stuff and immerse your brain inside the patient's vitreous, but you don't want to get too much in there. See how they respond intraocular pressure-wise. So, there we go. Next session, still in the mid-vitreous. I go back, start to cut the strands, but you can see it's much further away at this point. It's a work in progress. Sometimes these cases take up to 4 sessions. I've done 4 sessions. I had one patient come in with a retro implant floater. I couldn't get anywhere with 3 sessions, and she said, I think I want to stop, because she already paid for my fee, which is not covered by Medicare, which included 4 sessions. And I begged her, I said, please let me go back in. I know I can do this. Well, he said, well, I'm more than 50% positive I'll get a good result for you. She let me go back in, and sure enough, I got it out of her visual axis, and she was a happy patient. That's all that counts. The fee sometimes is secondary. I've had patients come in, and I tell them, I almost would like to pay you for letting me do this. This is so much challenging fun for me. Anyway, you can see it's out of the visual axis now. A little more. I probably had the patient back to get more stuff. But that is a happy patient. So, last but not least, I would like to thank you all for listening to this ponderous talk I gave. It's a little better than the actual live presentation, which was limited by time. They chased me out of the room because they had this doctor, glaucoma Flecken, giving a lecture or something like that. And I didn't have time to go over all these videos. So you're lucky. I hope you enjoyed it. Call me if you have problems. I'm more than willing to help. Thank you.